for the delay, everyone. For those of you who don't know me, I am Rebecca McGoldrick, and I'm the director of the Global Health Division here in the Anesthesia Department. And I first met Dr. Mugadza when I was a fellow. I was going to Zimbabwe, and she was a senior resident, right? And she had told me that she was wanting to start making regional curriculum for the other residents there. Because there was no formalized training, and I don't think there was any attending that had any formalized training either to teach it. So we made a couple video lectures, and then she went on through the WFSA to do a regional fellowship in India, and then came back and is now at the University of Zimbabwe teaching regional to the residents, or the registers is what they're called there. So I'll let her tell you a little bit about that.
Good morning, everybody. Thank you for that introduction. I'd like to thank you for welcoming me to come and speak to you about our regional anesthesia program in Zimbabwe. And I'd like to thank you all for coming early this morning to listen to me speak. So I'm going to tell you a bit about the regional anesthesia program, like Rebecca said, that we have in Zimbabwe. I have no conflicts of interest to declare. So just an overview. I'm going to give you a small geography lesson for those that don't know where Zimbabwe is. Then I'll give you a small introduction into how anesthesia is organized in Zimbabwe, because our training is different and the organization of the hospitals is also quite different. Then from there, I'll then zoom into the regional anesthesia, how we started, what we've achieved, and where we hope to go with everything. Okay, the objectives, I'm sure those that saw the poster have seen the objectives, but it's just to relate to you the anesthesia burden in Zimbabwe, and more specifically regional anesthesia, and then compare practice and organization between developing and developed economy. I think once I tell you how things are done in Zimbabwe and you see how we do it, you can then compare and contrast with how you do how you organize your system here. And then also just to understand what we've done in terms of developing our regional anesthesia curriculum and the service to our patients. Okay, so this is the map of Zimbabwe. This is my beautiful country, Zimbabwe, home to the mighty Victoria Falls. I'm sure we've all heard about it. It's neither the widest nor the largest, neither the widest or the highest, but it is the largest waterfall in the world. Home to what we call, this is an ancient historical city that the country is named after, and then we have lots of wildlife and lots of beautiful rock features as well in Zimbabwe. So Zimbabwe is situated in southern Africa. We have a population of 16.15 million, and that population is served by only 66 physician anesthetists. I shall speak more about the significance of those figures a little later. So I work with the Department of Anesthesia and Critical Care Medicine. So this is under the University of Zimbabwe, which is the oldest, was the first university in Zimbabwe and the oldest university in Zimbabwe. And our department services 2 of the tertiary referral and teaching hospital. And each hospital is about 1,000 bed each. In terms of theaters that we have, the one hospital has 12 theaters in main theater, 2 maternity theaters, and then the other one has 6 theaters in main theater, 2 maternity theaters, and 3 pediatric hospital theaters. So in total, we have about 20-something theaters. So how is the medical training in Zimbabwe conducted? It's very different from yours here. So we do a 5-year, after completing high school at the age of 18, you do a 5-year undergraduate degree program, medical degree program. On completion of the 5 years, you then do a 2-year internship. So during that 2-year internship, you rotate through medicine for 6 months, surgical department for 6 months, and then you do 4 months in pediatrics, 4 months in OBGYN, and then 4 months in either anesthesia or psychiatry. So not all our interns rotate through anesthesia. From there, you then have 3 choices. You can either go into a master's program. So, for example, I chose to go into anesthesia, which means you do a 4-year program in anesthesia, a 1-year diploma, followed by 3 years of master's. Some people choose not to pick the academic route, and they go into the district hospitals, which is outside the big cities, and they're called district medical officers. Of note is that these district medical officers are going to be conducting minor surgeries where they'll be conducting cesarean sections, and they also conduct anesthesia, but with no actual formal training in anesthesia. Then we have what we call our general practitioners. So those are people who then just go into, I think what you call family medicine here. We don't actually have formal training for family medicine. We just have general practitioners post-internship go in and then practice that way. So we'll talk about the many-faced God, or the many-faced God of our health sector. So we have our private hospitals and we have our public hospitals. So private hospital is, it's usually profit organizations. It's completely private. They get state-of-the-art care, probably hospitals very similar to what you have here. Then we have the public sector. So the public sector's got our government hospitals. For example, the two hospitals that I work in, Harare Hospital and Paranyatwa Hospital. Then we have our mission hospitals. These are usually faith-based and run by certain church organizations. So the anesthesia you get depends on which phase you're looking at. If you're in a private hospital, you're going to get state-of-the-art, very similar to here. But if you're in our public sector, those are your low, middle, and income level hospitals, nothing like what you have in the first world. So common things being common, I'm going to talk about the public sector. One, because that's where I work. Two, it's the one that services the majority of the population. And three, it's also the one that's responsible for training our medical staff. So these are just pictures of the two hospitals, Paranyatwa Hospital at the top, and that's our maternity hospital, which is at Paranyatwa Hospital as well. And then the blurred vision, sorry, at the bottom is Harare Central Hospital. Then we also have our provincial hospitals, like I mentioned, and district hospitals. These are on the outskirts and are usually serviced by our less qualified doctors. So let's look at the anesthesia workforce in Zimbabwe. I did mention earlier on we have 66 physician anesthetists. 35 of them work in the public sector, which means the other 31 are actually completely private. And of those 31 are all centered in the capital city, which means outside the capital city, we only have 4 physician anesthetists, which means the rest of the anesthesia is provided by what we call our non-physician anesthetists or nurse anesthetists. And then in the districts and the provincial hospitals, you have the nurse anesthetist as well as our district medical officers that I mentioned earlier. So why am I focusing so much on the numbers? What's the importance of these numbers? The Lancet Commission defines surgical specialist workforce density as the number of surgical, anesthetic, and obstetric physicians per 100,000 of the population. And the ideal number should be 20 per 100,000. That's looking at the surgeons, the anesthetists, and the obstetricians. And from that, they deduce that physician anesthetists should be 7 per 100,000. And then, so 2015-2016, the WFSA did a global anesthesia workforce survey to look at how many physician anesthetists we had for the population on the whole world. And they found that we had a density of 6.09 per 100,000. So let's bring that back to Zimbabwe. I said we have 66 physician anesthetists for a population of 16.15 million. That gives us a workforce density of 0.4 per 100,000. And just to show you where we are in comparison to you, you have 20.82. So you can see the burden of anesthesia is quite great in Zimbabwe. And I'm sure we're all aware of the Global Surgery 2030, which hopes that by the year 2030, we have a workforce density of 20 per 100,000, and for anesthesia of 7 per 100,000. So I think coming from our 0.4, we have a lot of work to do before we get to that 7. So how are we hoping to achieve this? Obviously through training. The University of Zimbabwe trains, like I said, it's the only university training anesthesia right now. And at present, we have 26 students in the department undergoing training. However, we do have 2 universities that are also starting training of anesthesia personnel. So we hope that will help us to increase our numbers. Then we also have to fight the big demon called brain drain. Since the department started, we've trained 88 physician anesthetists, but only 66 are left. That means we're losing a quarter of our physician anesthetists to the outside world because of the economic situation. But enough about the general anesthesia in Zimbabwe. Let's now zoom into regional anesthesia. So like Dr. McGoldrick mentioned, we met when I was still a senior resident, and at the time I had an interest in regional anesthesia, and it came to my attention that we weren't being taught regional anesthesia very well, and we didn't really have any consultants, what you call attendings, that were formally trained, that were working for the university. So I came across this quote at the time that is a very old one, but it says regional anesthesia is a skill that is seldom sought and poorly taught. And I think that was the classic situation that we had in Zimbabwe. This is a very busy slide, but I'm just trying to show you that there's so much out there that talks about the advantages of regional anesthesia, both economic, surgical, patient-related, and anesthesia-related advantages of regional anesthesia. But despite all that, there seems to be quite a lag in the teaching of regional anesthesia. So I pulled out this quote, which I know most of you are probably thinking it's very old, it's 17 years ago. But this was reported in 2000, and they said American students' training in spinal and epidural techniques was adequate and consistent since 1990. However, 40% were unable to perform a minimum regional technique required by the anesthesiology Residency Review Committee. So like I said, it's 17 years old for you, but this is very much the current situation in Zimbabwe. So I then came across this article, which I also read, which was talking about regional anesthesia in developing countries. And it talked about the challenges we face, economic, training-wise, the lack of the teachers. So it got us thinking in 2014, where are we in Zimbabwe with regards to the rest of the world and with regards to our regional anesthesia training? So after discussion with one of my senior consultants, we then decided to conduct a survey on a particular, we chose one particular type of regional anesthetic technique. We were already performing a lot of spinals and epidurals, so we then chose to look at the supraclavicular brachial plexus block. Why? Because it's often described as the spinal of the upper limb. You perform that, it allows you to perform quite a number of surgeries on the upper limb. So what we then did was we looked in our theatre registers and we looked to see how many patients taken to theatre over a 3-month period benefited from a regional anesthetic technique, be it for anesthesia or for analgesia. And then we also then chose to speak to the students. We did a self-conducted questionnaire that was given to the students to find out what they thought about their training in that one particular block. So these are the results that we found. So our survey of the theatre registers was done in the 2 hospitals that we work in. And at Harare Central Hospital, we found we had, over a 3-month period, 60 surgeries were performed of the upper limb that could have benefited from a regional technique. And of those 60, only 1 actually benefited from it, be it for anesthesia or analgesia. We then looked at the other hospital as well. And at the other hospital, 51 surgeries were performed, and not a single patient benefited from a regional anesthetic technique. And then when we spoke to the students, there were 23 students in the department at the time who all thought it was a necessary skill. But despite thinking it was a necessary skill, only 9 had actually ever been taught how to perform a supraclavicular brachial plexus block. And of note, this was very didactic type lectures. It wasn't anything, we don't have simulation labs. It wasn't anything practical. It was all very theoretical teaching. And of those 9 that had been taught, only 2 had actually ever performed one. So what we then did from there, we then developed what we call the learner-centered teaching module, because at the time I was still a resident. And we then went ahead and I was taught how to perform the supraclavicular brachial plexus block by one of our consultants who was completely in the private sector. From there, we then developed a module. So our module consisted of didactic lectures. We had workshops where we had phantoms. It's not a great picture, but we make our own phantoms with jelly. So we made phantoms to teach the needling. We had workshops on basics of ultrasound and knobology of the ultrasound machines that we have in the department. And then once this was done, I then taught the peers using the same similar module. Taught my peers using the same similar module. Then after that, we did a resurvey to see if there had been any change on the ground after the teaching module. And if you'll notice, I have the before and after figures. So over a similar 3-month period at Parinyatua Hospital, we had 63 surgeries done. And from that, it increased, the number of patients who received a block increased from 0 to 30. And at Harare Central Hospital, 53 surgeries were done and 11 patients received a block. Of note is that Harare Hospital is in the poorest part of Harare. So in terms of resources, they have a lot less resources than Parinyatua. So we always tend to get very skewed figures when we then do reassess at that hospital. So we then realized we had to focus on certain parts of healthcare domain. We need to focus on the workforce, which I've already mentioned because we're trying to train more anesthetists now. We needed to focus on the training. I'd only been taught at the time to perform 1 block in particular, and which was obviously not adequate. And from there, we then moved on. I applied for the WFSA Regional Anesthesia Fellowship, which I then got. I spent 6 months in India training in regional anesthesia. And I think the question's always been, is 6 months enough to learn enough regional anesthesia? But the workforce was quite great there. And I think in the 6 months, I did 155 upper limb blocks, 101 lower limb blocks, and over 30 truncal blocks. Just as well, when I then returned, the University of Zimbabwe is going through a curriculum review program. So when I then returned, I joined what's called the Health Educators Advanced Leadership Course of Zimbabwe, which is very much similar to, you have what's called the CTSS, that's run by Dr. Tanaka and Dr. Lau, I believe. So it's basically a program for health educators that teaches you about curriculum development and assessment and the likes. So as part of that, we then did a project to develop a regional anesthesia and acute pain curriculum for our MMed students. So those are our residents in the anesthesia department. So we did a needs assessment for this, and in the needs assessment, we spoke to the faculty, we spoke to qualified anaesthetists, and we also did a focus group discussion with the trainees. And the message that came out from this, the faculty felt that our regional anesthesia training was inadequate and more could be done. They also noted we had no formal curriculum and that we needed one that had defined goals and objectives. The qualified anaesthetists confessed to performing spinals daily and weekly, but peripheral nerve blocks were rarely done, sometimes monthly or even yearly. And 60% of them said this was due to lack of knowledge. Then when we spoke to the students, we did a focus group discussion with the trainees, and they felt that it was particularly inadequate in terms of practical training. They noted that a lot of emphasis was put on theoretical to be able to answer exam questions, but they weren't getting any practical training. And they all requested a formal rotation or a fellowship. So from our needs assessment and from the curriculum development that we then did, we've since introduced a regional anesthesia rotation. So we have a basics of ultrasound half-day seminar for our second-year trainees. And then in third year, we now have a 6-week regional rotation for the third-year trainees in anesthesia. So this is just to talk about, I thought it was important to talk about the evolution of anesthesia. For us, it started with interest and training. It now needs to go into research and development with the ultimate goal of better patient care. And just to put, give a picture to it, I decided to put in one case we managed a few months ago. It was a 36-year-old female patient who presented with shortness of breath for 3 weeks, which is associated with a cough of blood-stained sputum. She also had bilateral lower leg swelling for 3 weeks. The patient did have a history of rheumatic heart disease since 1989. So she was seen by the physicians who noted that she had a decompensated congestive cardiac failure, she was in atrial fibrillation, and she also had DVT. 3 days later, this is what developed in the patient's upper limb. She was noted to have a cold right upper limb, and radial and brachial pulses were not palpable. Her echo showed she had a severe mitral regurgitation, mitral stenosis, and the AF. The vascular surgeon was called in, who noticed she had a gangrenous upper limb secondary to a cardioembolic event, and that she needed to go in for an amputation plus or minus embolectomy. Unfortunately, our anaesthetist that was present at the time thought she was a poor candidate for general anesthesia. And before, this is either a patient who would either have received a very turbulent general anesthetic or would have been abandoned until it was a very turbulent path. Lucky, she then got in touch with the regional team. We took the patient to theatre. She had an amputation done under a supraclavicular block and was discharged to the ward and home eventually. So these are patients who before this we probably would have struggled to manage. So the question then is, are we on the right track? I'd like to think we are. We have a growing faculty with regional anesthesia training. Like I mentioned, we have one in the private sector, and we've managed to attract 2 more to join the public sector and the teaching university. In terms of resources, which tend to be very limiting in our setting, we now have a total of 4 ultrasound machines available to the department. And now we've now since formed a regional anesthesia and pain medicine special interest group, which has 4 that are trained and 3 who have a special interest but are awaiting training. And good news is we had our first workshop that was conducted by the Regional Anesthesia and Pain Medicine Group at our annual Congress in Victoria Falls last week, in which we did a workshop that was titled Upper Limb Blocks Every Anesthetist Should Know. So these are just a few pictures from the workshop that we conducted. So I say to us, dare to dream big. This is me jumping 111 meters off the Zambezi Bridge last week. So what's the big dream for us? The big dream for us is to develop a regional anesthesia fellowship in Zimbabwe. And how are we going to get there? I like to think with the beauty of global health is we're involved in a lot of collaborations between different parts of the world. So we think the way forward is for us to collaborate with other parts of the world, both within our own continent and outside of Africa. We want to look into research, because through research we can then help further develop our regional anesthesia program. We're hoping to get regional anesthesia fellows, global anesthesia fellows visiting Zimbabwe, and Zimbabwe visiting the outside world as well. And then we also hope to entice more students into the program by having exchange programs for our trainees and our fellows. So in conclusion, I will say that regional anesthesia training and service in Zimbabwe is in its infancy stages, but it is steadily growing, and it's benefiting our society and our patients. There's lots of opportunities for collaboration through education and service, and I'm hoping that this will help our fellowship to eventually develop and grow. Thank you. Any questions? Yes. Okay, thank you for that very interesting question. I think it's a very difficult, I think if we had the answer, we would have done it a long time ago. But it is a question we do keep asking ourselves. It's partly economical, it's partly to do with lifestyle in Zimbabwe, and it can also be very frustrating to work in our government hospitals because of resources. So what we are trying to do now, I think through a lot of our collaborations, things are slightly getting better. We've got incentives that are being put in to sort of retain faculty within our government hospitals and to not lose them, be it to the private sector or to the outside world. But if I'm honest with you, it's a very difficult thing to do because of the economic situation, because of the political situation. So as those start to repair themselves, the assumption is we'll be able to hold on to more of our staff than we were before. Yes.
What were some of your biggest challenges in trying to implement change in your practice?
Okay, so the first challenges we had, there was several. The first biggest challenge we had was resources. When I started, we only had one ultrasound machine in the department. And like I mentioned to you, we have 20-something theaters. So it was very difficult to work around that. But we then managed to get a few more, we managed to convince the hospitals to acquire more ultrasound machines for us. Then the second challenge we had was in terms of disposables. Drug shortages are quite a big problem at times in Zimbabwe. We had problems with the needles as well, getting those in. But we've since managed to get a steady supply of them because they've realized the importance of having it. And I think we've managed to convince hospital administration that it's actually economical to go the regional route than the general anesthetic route. So that's worked to our advantage. Then I think the biggest obstacle we had was actually the workforce itself. It's very difficult to change people's mindset and people's old habits. So we had to retrain and convince people of the advantages of going the regional route. There was a lot of resistance from the senior anesthesia staff and the junior staff who just thought, why do I need to learn this if everybody else has been doing it one way and have done fine all along? But I think through our workshops, we've done a lot of re-education of our workforce to get there. So those are the obstacles I think we faced, the biggest obstacles we faced.
I think that's a worldwide problem.
Oh, okay. It's good to know.
How did you choose ultrasound exclusively as your the basis of training your localization versus
Other means. Well, we thought if we start with landmarks, we did have people that were doing landmark techniques. But we thought the rest of the world is moving to ultrasound. If we start 20 years behind, when we're already 10 years behind, we're never going to catch up. So we decided to start with ultrasound because it was the most modern form that there was. And once you have that, you could always learn backwards if you needed to, but we wanted to be current and in tune with the rest of the world. Hands have gone down. We did have that problem where we had initially, but I think we were sort of lucky at the time. We had a lot of missions that were coming to Zimbabwe who came with the needles, and then since then we've managed to convince hospital administration to acquire them for us as and when we need them. Yes.
Before you guys started the virtual operation, that like you said, it was probably a long route to some kind of existing way of taking care of people. So how did what sort of economical arguments were you able to use to try to convince the hospitals that buying other expensive ultrasound?
So we were actually, how we got the ultrasound machines, like I mentioned, we already had one that was available in the department. The second one we got through a grant because of one of our pain fellows was doing stuff with ultrasound. So she managed to get the machine through that grant. Then the third machine was actually donated to one of our other hospitals. And the fourth machine, one of our consultants in the private sector then chose to just purchase his own. So we didn't need to convince the hospitals to buy us those. What we did need to convince them was the needles and the drugs. And the argument we used was, for a general anesthetic, you're going to have an induction agent, you're going to have maintenance gases, you're going to use oxygen, and whatever balancing gas you choose to use. But if we go the regional route, it's the needle, it's the marcaine, and then you monitor the patient. And that seems to be able to get us what we wanted. Yeah, we did. I think that, I don't know if that's a problem here, but we did have that problem with the surgeons initially, because they have this mentality that regional is going to slow down their list. But how we're very lucky, how our theatres are structured is every theatre has a pre-anesthetic room. So we would bring our patients into the pre-anesthetic room, conduct the regional anesthesia in there. So by the time they finish their case, the patient's good to go. And then our patients love to see a patient the next morning. I mean, our surgeons love to see a patient the next morning who's not in pain. So they realized all the patients that got regional were pain-free the next morning. So that sort of got us buy-in from the surgeons as well. Yes, these are single shot blocks. We unfortunately do not have catheters, and we don't put catheters in. One, because we don't have them. Two, there's a lot of concern with our nursing staff about monitoring patients who have catheters in. No more questions? Okay, thank you very much for your attention.